Hey, everybody. Welcome back to Pulm Peeps. Thanks for tuning in and downloading. We always appreciate you joining us to talk through a fun topic in pulmonary and critical care medicine. Best part of my week or every week that I have this is being here with everyone. And as always, with my partner in crime, Christina Montemor. Monty, how's it going?
Hey, Firth, going well. I know. Favorite part of the week when I get to see you, and we get to do things like this. We've been on a pretty great Fellows Case Files tour, and we're super excited to be virtually visiting the University of New Mexico. So super excited to be expanding our program and learn from some great clinician educators as well. And first, I'd like to introduce Dr. Neel Vahil. Neil's a second year internal medicine resident at the University of New Mexico. He completed medical school at New York Medical College and is planning on applying to pulmonary critical care fellowship programs this summer. So, Neil, in just a few months, everyone's going to be looking out for your application. It's a great time to welcome you onto the show, Neil. Welcome to Pulm Peeps.
We're huge fans of the show. Thanks so much for having us.
Yeah, absolutely. It's our pleasure. We've loved it that a lot more internal medicine residents have been reaching out to us. A lot of Pulm Crit love, which is like whatever in our special place in our hearts. So thanks for emailing with us. Next, we have Dr. Ishan Patel. Ishan is a third-year pulmonary critical care medicine fellow at the University of New Mexico and will be pursuing a second fellowship in clinical informatics this year. He completed medical school and residency in internal medicine at Oregon Health and Science University. His fellowship research is focused on clinical outcomes of intensivist-led ECMO programs, all stuff that I'm super interested in. I love it. So thanks for coming on the show, Isha.
Hi, everyone. Thanks for having us on.
Yeah. So, and informatics, I'm super into informatics right now. I feel like I didn't know this was a fellowship, and now recently I've been talking to a million informaticians. How do you? Well, I'm not sure what they go by, but they're like the coolest things in medicine. So I'm very impressed.
Thank you so much.
And lastly, we have Dr. Lucie Griffin, who completed an internal medicine residency and pulmonary critical care medicine fellowship at the University of New Mexico and is currently the director of the Albuquerque VA Medical Intensive Care Unit. Thanks for joining us, Lucie.
Great to be here.
Wonderful. And so excited to have you, the three of you on. And just quickly, before we get to our case, we'll do our quick disclaimer. And just as a reminder, the podcast today is not meant to be used for medical advice. And the views that we're going to express do not necessarily reflect the opinions or policies of our respective employers. The case today is HIPAA compliant, and some details we have changed to protect the privacy of our patient. So with that, let's go ahead and get started. And Neil, would love for you to have us tell us about the patient that you met and how they initially presented.
Certainly. So we met our patient in pulmonary clinic, and he was a 69-year-old male with a history of ongoing tobacco use and a long-standing history of seropositive rheumatoid arthritis on chronic immunosuppressive therapy, who presented with 6 weeks of weight loss, cough, and malaise. There was no history of recent infections, hospitalizations, or any other significant changes to his health other than having a 3-month lapse in his rheumatoid arthritis medications due to prescription filling issues.
Thanks. And we'll even pause right here just with a little bit of information. I love that we're doing a case that starts in Pulm Clinic. You know, we often meet people in the hospital where you have so many tools at our disposal to get information right away. Pulm Clinic is how we meet the vast majority of our patients. Sometimes we have some tools we can't get in the hospital, even like bedside PFTs are a little harder to get than clinic PFTs. But also, we just have to rely way more on our traditional history, physical exam, and then decide on our next steps. So, a great place to start this off. At the outset, we have an elderly man who's got continued tobacco use, huge thing for us to note, presenting with weight loss, cough, and malaise. And my initial differential for this type of patient, who I get all the time, I actually even start this differential when I'm chart biopsying in advance and writing my note, is relatively broad and focused on some of these infectious inflammatory etiologies, and then based on his risk factors in his history. So he has a smoking history, weight loss. We're all going to be thinking about cancer, right? It's going to be on our differential. That being said, I also think in smoking history, bunch of pulmonary diseases that maybe have been under-recognized or undermanaged so far. Could have undiagnosed COPD, which could certainly lead to weight loss as we get pulmonary cachexia. Could have ILD. We know smoking increases the risk factors for that. Pulmonary vascular disease as well. In addition, he's got rheumatoid arthritis with a lapse in his medications. This can be an extremely inflammatory disease in some patients and have a number of pulmonary manifestations. Could have associated ILD and certainly a range of other findings. And so I'm thinking about these and how they're influencing us. In general, too, if he has rheumatoid arthritis, I want to know about his underlying disease, but also what medications was he on? If he was on immunosuppressive medications before, he could be more prone to chronic indolent infections, MAC infection, which can present with weight loss and cough, things like that. So these are all going to be parts of the history that I'm going to want to try to get going forward. Neil, would you mind giving us a little bit more background and tell us what he looked like and some other information when he first presented?
Yeah, absolutely. So I mentioned a bit about his medical history, which was notable for seropositive rheumatoid arthritis and tobacco use disorder. But his medications specifically included daily hydroxychloroquine, weekly methotrexate with infusions of etanercept. He had no surgical history and no known drug allergies. And his family history was remarkable for lung cancer in his dad and colon cancer in his brother. His social history was notable for a 50-pack year smoking history. He would drink 2 to 3 glasses of whiskey a week on average, and his exposure history was remarkable for a history of asbestos exposure. On exam, he was well appearing, afebrile, and slightly hypotensive with a blood pressure of 93/59. He was mildly tachycardic to 101, saturating in the mid 90s on ambient air. Pulmonary exam was notable for decreased breath sounds in the right lower lung field, and musculoskeletal inspection demonstrated chronic findings of elbow contraction on the right, but otherwise reflected a benign skin and joint exam without redness or synovitis. And his labs were only notable for moderately elevated acute phase reactants.
Awesome. Thanks so much, Neil. And I think just some great information and quite a bit to work with. And just thinking about your physical exam as well, I think probably based on this, where you're noticing decreased breath sounds in the right lower lung field. I know POCUS, or when I talk POCUS, is trending and is a lot of curriculum in IM as well as PCCM. And this would probably be someone who, if you notice that abnormality on your initial exam, going to the bedside and just looking with ultrasound to see is there a potential consolidation or an effusion that would help also frame your differential. FERF gave us a really great framework to think about. He talked about 5 bigger buckets earlier. And again, the first one was infectious etiologies, second being undiagnosed parenchymal or airway disease, third being pulmonary vascular disease, fourth pleural infection, and then the fifth one, just with a longstanding smoking history, you always want to make sure that we are mindful of a potential pulmonary malignancy. A couple of other things, the history of tobacco use that you mentioned. I want to know if he had any previous spirometry that might be pointing to some underlying obstructive disease that could help explain some of the symptoms that he's presenting with. As we just talked about with the infectious etiology, decreased breath sounds, potentially looking for an pneumonic effusion or an empyema. Could he have had a community-acquired pneumonia, possibly in the context of underlying lung disease, or tuberculosis could also be raised. The subacute time course, though, makes an acute process somewhat less likely. Can't completely rule out everything. I think another interesting thing, Neil, that you mentioned is just his history of rheumatologic disease and lack of adherence to his immunosuppressive medications. Could we be seeing a connective tissue disease associated pulmonary disease or that may be manifesting in a more chronic fashion? And then you mentioned 3 medications he was on that could have some immunosuppressing effects, including a TNF alpha inhibitor. I know in prior episodes we've talked about this, but those can increase the risk for mycobacterial infections and atypical bacterial infections such as Listeria or fungus. Just briefly to summarize again, we have a 69-year-old male with a history of rheumatoid arthritis, longstanding tobacco use, who came in with a 6-week history of cough, malaise, and weight loss, with grossly unremarkable laboratory data and pulmonary exam findings of diminished right lower lobe breath sounds. So Ishan would love to get your thought on this and wondering if you could discuss some of the indications for imaging at this time. Are there other tests that you would like to obtain at this point? And I guess a follow-up question already. If you are thinking about imaging, can you tell us what modalities you would prefer to get at this point in his care?
Sure. We're seeing this patient in our outpatient pulmonary clinic, as Neil had mentioned, and one of our best first initial imaging tests for us to obtain would be a simple chest X-ray. It is cost effective and can quickly help us identify any gross abnormalities ranging from alveolar or interstitial edema, a large lung mass that might signal either a secondary or primary malignancy, flattened hemidiaphragms or a narrowed mediastinum that might indicate a moderate to severe emphysema, mnemonic consolidations, and pleural effusions. So a lot of information that we could get from one of the imaging modalities that we've been using for quite a long time. A CT would be better. A CT of the chest would be better if we wanted to rule out more subtle lung pathologies and might help us determine if the patient had developed connective tissue associated interstitial lung disease. A CTA, on the other hand, might help us rule out pulmonary vascular disease such as pulmonary embolism, though this would be less likely based on the subacute nature of the patient's presentation and the physical exam that Neel had described earlier. I wouldn't hesitate to get spirometry either, since this can also help us determine if there is an obstructive or restrictive process at play. And we can also use this to help us determine if diffusion limitation process is present by looking at the diffusion capacity.
Great. Thanks so much for going through that. So we have some great options of what we could get next. I think these are like the key tests that we're always thinking about. Neil, can you tell us about what sort of imaging that we pursued and what kind of initial results we had?
Sure. So, as Ishan mentioned, the first imaging test that we obtained was a chest x ray, and that showed bilateral pleural effusions greater on the right side, as well as some right upper lobe opacities that were new since the last chest radiograph, which had been obtained 6 months prior. The patient also underwent spirometry, which was notable for a mildly reduced DLCO, but not significantly changed from prior. Because of the presence of new bilateral pleural effusions and interstitial opacities, we got a formal echocardiogram, and which was obtained, and that demonstrated normal left ventricular function without any evidence of diastolic disease. A subsequent non-contrasted CT was then obtained, which demonstrated a new right moderate pleural effusion with chronic findings of paraseptal emphysema. The presence of a new onset right-sided pleural effusion prompted our team to pursue a diagnostic thoracentesis.
Yeah, I love it. This is great information. A couple things I'll point out here. We noticed the DLCO wasn't shut down so much more from prior. But when we think about the combination of like pleural effusion and DLCO, so like how could those things be linked? One thing in the DLCO that we often don't look at, we often look at the corrected, uncorrected, but is the volume of alveolar ventilation that is used to make that calculation. So the classic thing, if you take somebody and do a pneumonectomy, their DLCO goes down in half, even though their lung is still healthy in there, right? So the diffusion across that lung is the same, but the volume is less. And so if you have a patient and their DLCO does go down and they have a massive pleural effusion, you could look and be like, oh, maybe it's just that their volume of alveolar ventilation has cut by some significant factor. And so just another line in the PFTs that I always make sure to take a look at. And then, you mentioned that this prompted you guys to think about thoracentesis, which I think is the right thing. And you guys have basically a new unilateral effusion. I know it says bilateral, but you're looking at right way greater than left, right? So that makes me think more about a unilateral in a patient who's got multiple risk factors. And you've actually done a really thorough job and said there's not some clear explanation for this. There's not some heart failure on the echo that we say, oh, this is clearly just a gross volume overload. So a new unilateral. If you haven't heard our episode on pleural effusions, we suggest you go take a listen to that. But we would say that this would be our indication for some sampling, which can help us with our next steps. So Ishan, what did the thoracentesis show?
So we got him into our pulmonary diagnostic lab and did a thora that we removed 1 liter of about a greenish turbid fluid. And the fluid studies were consistent with an inflammatory exudate with 81% neutrophils, 4% lymphocytes, a glucose that was less than 20, a pH that was low at 6.8, and an LDH at 10,389 with an ADA level of 157.
Oh, thanks, Ishan. Those are some pretty impressive numbers, right? And just screaming out. That's one of the highest LDHs I've seen in a pleural fluid study. So definitely infection, but some or other inflammation still very high on the differential. And green fluid, I personally haven't seen pleural effusion that drains green fluid, right? I do CF, so I see a lot of green sputum in clinic. In the ICU, we see the green urine with propofol, but this is a little bit new for me too. So, Lucie, I would love to hear your thoughts on what you think, first of all, what you think when you see pleural studies like this, and anything that you want to comment on the green fluid and the nature of the fluid in this situation.
Definitely. So I think, honestly, for me, the most important thing was to rule out an empyema. His pH is very low, and the LDH, as you noted, was very high, as well as the glucose that's really low. So this means that there are a lot of cells in the pleural fluid. If this is because there are bacteria or PMNs, then there is some acute management may be needed. But this can also be seen in things like a chronic effusion from malignancy or autoimmune diseases like rheumatoid arthritis. In those cases, there are a lot of cells in the fluid. I will say that the green color that we saw is thought of for concern for a rheumatoid associated effusion.
Thanks, Lucy. Yeah, I have heard that too. I tried actually looking up before this. Is there a sensitivity, a positive predictive value on green pleural fluid and it being rheumatoid arthritis? And I think this is having to do with the amount of cells are in there and the processing of the elevation of the protein, the processing and decreasing the glucose there. I couldn't find any data. So if anyone listening has data on how useful of a sign this is, definitely reach out to us. We'd love to share it with everybody. All right, so Yushin, can you tell us about some further studies, cultures, other things that we got off the fluid and what they told us?
Yeah, so we ended up getting bacterial, fungal, and AFB cultures on that pleural fluid that we obtained, and all of those turned out to be negative. And a few weeks later, he happened to be coming back to the clinic for another reason. And I took him aside and I said, let's take a look and see if there's another effusion there. And sure enough, another effusion had reaccumulated. So we consented him and obtained another sample of about 350 cc's of, again, greenish turbid fluid. And in the second thoracentesis, the fluid studies were similarly consistent. Again, inflammatory exudate with high amount of PMNs, 79%, and then 4% lymphocytes. Glucose, which was again very low, pH that was at 7.03, and a high LDH at 6,500. The ADA level on this second sample was similarly high at 97. And we sent that second thoracentesis fluid for cultures, including bacterial, fungal, and AFB, and they were once again negative. We sent a small sample down to cytology as well, which was not consistent with malignancy. On that second fluid sample, we ended up sending the fluid for rheumatoid factor, and it was found to be elevated at 31. And that made it reasonable to conclude that the etiology of the pleural fluid was from the patient's underlying rheumatoid disease.
Thanks so much, Ishan. I think such a great example where this personalized and individualized medicine that you provided for this patient coming back to clinic. You're looking with ultrasound and just doing the procedure there, not having him come back and forth to the hospital. And you're able to get a lot of great information. And I'm sure at some point we'll talk more about the rheumatoid factor in the pleural fluid and the elevation of that going forward. But just thinking broadly, rheumatoid arthritis has a bunch of pulmonary manifestations that we may be seeing, obviously, within internal medicine and within pulmonary critical care medicine. And Neil, I'm hoping you could tell us a little bit more about rheumatoid pleural diseases that listeners should be aware of.
Yeah, definitely. As far as pleural disease goes, this is generally seen more often in older patients and those who have rheumatoid nodules. Though bilateral effusions are common, I would say most are unilateral. And the pathobiology is hypothesized to be related to impaired fluid resorption in inflamed pleura, as well as local cytokine production that then generates an endothelial injury and capillary permeability. The CT is generally better for evaluating rheumatoid pleural disease, and a thoracentesis should be performed for any effusion that can be safely sampled, as Dave said. The pleural studies generally yield a low pH, usually less than 7.3, low glucose, typically less than 60, and an elevated LDH, as in our patient. Typically, these values are greater than 700. The biochemical characteristics of the fluid can certainly be mistaken for a serious bacterial empyema, as was mentioned before. However, rheumatoid factor is often present in the pleural fluid, and it may be higher than the serum levels, as it was in our patient, and this can help differentiate between these two entities. TB and malignancies can also mimic rheumatoid pleural effusion, and that's why it was so important to rule out both of these clinical entities in our patient, especially in the setting of immunosuppression. If effusions are small and asymptomatic, they generally don't require any specific interventions, and management typically hinges around managing a patient's underlying rheumatoid arthritis. There is literature to suggest that while systemic manifestations of RA may be missing, isolated symptomatic effusions from RA should warrant an increase in immunosuppressive therapy.
Yeah, thanks, Joe. I think you hit on a bunch of interesting points here. We heard in our episode about empyema about how serious a paraneumonic effusion or empyema is, especially you get one, the pH comes out really low, the glucose is low, the LDH is really high. Those patients, we like to try to put a chest tube in right away. We like to try to often do enzymatic therapy right away. We're not sitting on that empyema overnight. So when we get a mimic of empyema like this, we have to be really thoughtful and look at the patient and say, hey, is this story as consistent with this? Could there be another explanation before diving forward with that? It sounds like you guys did that in this case. I also want to touch on the fact that rheumatoid factor here is really interesting. This is one of these these are antibodies. It gets a variety of antigens that we see in rheumatoid arthritis and some other diseases, but they're really showing as like a marker disease activity, and especially in this local space. So it's not just the thing that we use to make the diagnosis. In this case, it's showing us how much disease activity is here localized in an area of the body. And so that helps guide our therapy. And then just like you said, that means we need to do better job controlling the rheumatoid arthritis. There's not much else that we can do about this mechanical problem if they continue to have inflammation from those antibodies. So really cool stuff that we're talking about and good points so far. But these are not the only other things in RA that can happen with lung disease, right? So we had this patient, he had clearly this diagnosis, but we should be having a differential before about RA associated lung disease. So Neel, I know you learned a lot about this case. I was hoping you could walk us through the range of other pulmonary diseases that we should consider in a patient coming to our clinic with rheumatoid arthritis.
Yeah, like you mentioned, there are an array of pulmonary diseases associated with rheumatoid arthritis. And interstitial lung disease is the most common pulmonary manifestation of RA. Monty actually mentioned that in her initial differential. It's estimated that up to 30% of patients have subclinical interstitial lung disease present on high resolution CT, with a recent study showing that up to 10% have clinically significant disease. There seems to be a higher risk associated with males who continue to smoke. Airway complications of RA can include rheumatoid nodules on the vocal cords and vasculitis affecting the recurrent laryngeal or vagus nerves. As we travel down into the lower airways, you can also see bronchiolitis or bronchiectasis. Small pulmonary nodules can also be seen in patients with long-standing disease, and these are usually asymptomatic unless they cavitate or rupture. Pulmonary vascular disease has also been described. However, this is usually in the context of patients with underlying parenchymal diseases such as ILD, and so it's thought to possibly be connected to that. Lastly, many of the immunosuppressive agents that rheumatoid arthritis patients take have been associated with drug-induced pulmonary toxicities. Hypersensitivity pneumonitis has been described in the literature and is possibly associated with higher doses of methotrexate or leflunomide.
Awesome. Thanks so much, Neil. And definitely, I think those listening today can have a better understanding of both pulmonary manifestations of RA as well as some extra pulmonary manifestations. I think you bringing up the possibility of having RA nodules, vocal cords, or potentially vasculitis are definitely things that we should be looking out for. So I'll say now we have a patient with twice sampled pleural effusion. You successfully have ruled out TB, and the pleural fluid studies are not consistent with the malignant pleural effusion. Two topics and points that we have definitely talked about already, and so it's important to rule out. But so we now have a patient with pleural fluid characteristics suggesting a rheumatoid pleural effusion. And now, love to turn a little bit. Now that we have this, what do we actually do, and what implications does this have for management? And Lucie, I'd love for you to share with us your thoughts on this.
Definitely. So when I think about what I would do for a patient like this gentleman, I think about how they're presenting to clinic. Are they short of breath? Are they reporting functional limitations? Because that might prompt me to consider a repeat therapeutic thoracentesis. On the other hand, if they're asymptomatic, observation alone is usually appropriate. In fact, in a case series of patients with rheumatoid effusion, all had resolution of the effusion within 3 years, with an average time to resolution of 14 months. More broadly, management of a patient who presents with a pulmonary manifestation of a rheumatoid disease, like rheumatoid pleural effusion, should prompt us to engage our rheumatology colleagues so that we can consider if more optimal pharmacotherapy for the patient's underlying RA is warranted. Of course, once infection and malignancy have been ruled out. To me, this case is a terrific example of how close cross-disciplinary collaboration with rheumatology can help us coordinate his treatment to facilitate the highest quality of life for our patient. And actually, In this case, that is exactly what we did. Our patient was started on tocilizumab to target more aggressive control of his underlying disease.
Thanks so much for sharing that, Lucy, and giving us a little bit of pearls for management. And I think if you haven't gotten it by now, I think my teaching point or learning point for the day, I'm going to insert that now. I think we've said a couple of times, one thing that we need to underscore is ruling out infection or malignancy before you settle on the diagnosis of a rheumatoid pleural infusion. Because suspicion of either could temporarily mean that we are going to withdraw or hold a patient's immunosuppressive therapy, while the diagnosis of rheumatoid pleural effusion may ultimately lead to a patient's rheumatologist to uptitrate or add new agents to optimize treatment. So yeah, I think this, again, this case has just helped me realize how important it is to sample these effusions, high index of suspicion, rule out malignancy and infection before we move further with treatment.
Some of the confounders that we were working with through this case relate to the speed at which the different results have come back to us. We're in pulmonary clinic. We're in the pulmonary diagnostic lab. We send some fluids down to the lab. We can have simple biochemical analysis like pH, glucose, LDH levels come back within hours of sending that fluid down to the lab. But other testing may take days and often sometimes weeks if we're having to send out to specialty labs across the country. And in that time frame, we could have made treatment decisions based on incomplete information or information that might have changed our management for sure. So it's important for us to keep that broad differential and reassess that differential once that additional information comes back. And an interesting finding in this particular case was the high ADA or adenosine deaminase level that we found in the effusion. Normally, we associate a high ADA level in the literature to something like tuberculous pleurisy and lymphocytic predominant effusions. And remember, in our case, we had a more neutrophilic predominant effusion. And then, certainly, in a patient with immunosuppressive therapy, ruling out tuberculosis or making sure that this person doesn't have tuberculosis is of utmost concern. But we found in our literature search many examples supporting that pleural fluid ADA levels can be quite high, especially in non TB cases such as rheumatoid effusion, like in our case, or malignancies. And we ensured that we ruled out active pulmonary and extrapulmonary TB, of course, but we kept a fairly broad differential and ensured that we ruled out other pathologic processes given the stakes of that treatment.
Yeah, thanks for going through that, Ishan. I feel like this is a shift. I feel like classically we hear exactly like you said that ADA, tuberculosis, but when you look into it, it's really just not that specific. It has some sensitivity, but it's just not that specific. And are still in the world of developing appropriate test characteristics for our rapid NATs that we're using for bronchs to rule out TB on pleural fluid, but those can be a helpful test when we're saying, hey, this ADA is high, but I'm not sure that this picture fits. So we really have to go based on culture, which is still the gold standard for that. All right, so the patient had this diagnosis was made. We talked about increasing the management, and they were started on tocilizumab, which I know is like a really new, not so new, but a drug that's being used much more popularly in rheumatoid disease, especially when we want to focus on the lungs, right? So as we mentioned, methotrexate, leflunomide, some of the cornerstones, we worried sometimes about pulmonary toxicity. So we're using this more. So how did he do after the toci started?
So 3 months after that second thoracentesis we did, he had a repeat CT of his chest, and it showed, again, another moderate right, now hydropneumothorax, which was radiographically suggestive of ex-vacuo and fibrothorax. But he was completely asymptomatic from this. He had no exercise or functional limitation. And we saw him in clinic again 6 months after that, where he actually reported feeling subjectively better than his initial presentation. He had some residual shortness of breath, and we had a very extensive discussion about kind of the sequence of events leading up to these imaging studies. And we discussed with the patient the likelihood of success of releasing that fibrothorax to relieve the ex vacuo during thoracic surgery. Because my impression was that the risk of surgery was prohibitively high for an uncertain benefit, and given he was minimally symptomatic, I recommended that he not pursue thoracic surgery. Some small studies have advocated for the use of intrapleural corticosteroid therapy in cases of recurrent rheumatoid effusion to avoid this complication. And the role of pleurodesis and decortication has not been super well established, but case reports have demonstrated success.
Yeah. Yeah, absolutely. This is what happens to these patients. So, just to say out loud, I had this pleural effusion for a very long time. And so it's less about the etiology and more about the time that's there, right? So the pleural tissue just gets really fibrosed and you get this rind and you have trouble re-expanding the lung. When we think about what we're going to do going forward, the decortication surgical option is sort of the gold standard. Like exactly as you said, you have to think about the risk benefit. If they're not symptomatic and the lung's not re-expanded, we worry a little bit about accumulation of fluid in that space and if it can get infected, but mostly people tolerate that just fine. They have a little bit of a chronic reduction in their lung volumes, and we have a lot of redundant lung volumes. I'm saying a decortication also, it's not the easiest procedure in the world, right? Depending on how locked in that lung is, can be still VATS, sometimes can be open, but often on VATS. But a lot of times there's healing off and trying to get that lung to come up. And they can have great success rates with a really good thoracic surgeon, certainly. But it takes a certain real amount of recovery and doing a risk benefit of how big this entrapped lung is, how symptomatic the patient is, and how likely they are to benefit from the surgery, I think is exactly right, as you did. I also just want to make one more point here before we wrap up because this is a super interesting case. We talked about rheumatoid pulmonary manifestations, and one thing we mentioned was like methotrexate and leflunomide. And this comes up a lot, right? So these are classically thought to cause pulmonary toxicity, but there is a lot of data out there now that for pulmonary fibrosis, these medicines are actually still safe most of the time. So you really, I think there's this gut reaction quickly to say, oh, they're on methotrexate, they have pulmonary findings here. We have to stop it. We have to switch to something else. And that can be the safe thing to do. But there's a number of articles, and we'll share them on the show notes of this, showing that this can be safe unless you really think it was the drug that caused it. So you have to look at temporal relationships. You have to try to investigate. That can be tricky, but I don't want people to leave thinking, okay, you have some pulmonary manifestations, got to be off these drugs right away if they're working really well for the other rheumatoid.
That's such a great point for us to remember. And I just think a terrific case. And I just want to, I think, reminding ourselves that Neel and Ishan, this was a patient that you successfully managed in the outpatient setting, right? Which is very different from some of our other episodes where it's inpatient and we're able to expedite things. But I think really clinical context here, you were able to use providing him still optimal care in an outpatient setting, I think Ishan, when you were mentioning too, just like the hydropneumothorax, if someone saw that, wasn't looking at the patient or talking to them directly, would someone have gone in and tried to put in like an urgent chest tube, and that could have changed time course and ultimate management for him. But just really wanted to say thank y'all for bringing this up, and I think a great example of successful outpatient management.
Yeah, absolutely. I love having a case that takes place mostly in the clinic. Thank you guys for joining us today. This was really great. We love coming around, meeting new people. I've never been to New Mexico. It's on my short list of places. Actually, I'm near the top of places that I want to go. But I'd love to hear more about the University of New Mexico, what you guys like about being there, training there, and working there, maybe a bit of the pulmonary critical care medicine division and fellowship. So Neel, maybe we'll start with you.
Yeah, absolutely. I'm truly in awe of the work that the nurses, pharmacists, physical therapists, advanced practice providers, and physicians do at the University of New Mexico. There's this overwhelming kindness, I think, that permeates this institution, and the folks here are truly dedicated to taking care of not just the patients, but their families as well. So it's been an honor for me to train here, learn from, and care for the people of this beautiful state.
And I would echo exactly what Neel said and add that we're a small academic group dedicated to the people of New Mexico, and the pathology here is quite varied. And some of the most rare diseases that trainees read about, we are actively managing as part of fellowship and learning about. Part of what makes training here so unique is that we have many interesting cases. We have the great outdoors, beautiful mountains and fields, and so many fun things to do outside, as well as friendly and nice people to work with, which makes for an awesome and great training environment.
And I would, of course, agree with both Neel and Ishan on this. I'm obviously quite biased as I did residency and fellowship here and then decided to stay on as an attending. As an underserved state overall, we do get the privilege of taking care of people who really seem to appreciate it. And I really believe that our program, although small, does offer great clinical training, not to mention that you do get about 310 days of sunshine a year.
That's pretty nice. Can't argue with that.
I know. I love that. So, I mean, I think the three, it seems like sunny days, mountains, nice people. I'm not really sure what else you can ask for, but in addition to the great clinical training and patient care. But we've had an absolutely fantastic time having the three of you join us today. And as we wrap up, as I did mention one of my takeaway points earlier in the day, but a second one is just thinking that you can add rheumatoid factor in the serum, but you can also add it from pleural fluid studies if you're concerned about pleural effusion in the setting of rheumatoid arthritis. Firth, what about you?
Yeah, I like that. And I'm going to add another plural study, Pearl, that we talked about. Ishan talked to us about ADA and how we often think about it as tuberculosis. It should raise suspicion, but it may not necessarily be specific. It can be elevated in other conditions like rheumatoid arthritis or malignancy.
Neel, what about you?
Yeah, I think for me, the biggest takeaway is how important it is to sample new effusions in patients with underlying connective tissue disease, as long as it can be done safely, because it can have enormous implications for management.
Awesome. And Ishan provided a therapeutic and diagnostic safe procedure in the clinic. Ishan, what about you? Any points you want to highlight today?
Yeah, so my biggest takeaway in general is to continue to maintain a broad differential and refining that differential with information as you get it. Anchoring bias can definitely result in dramatically different outcomes. And like this guy, he could have gotten a urgent chest tube with that hydropneumothorax, or maybe a concern for empyema, he could have gotten a chest tube that really potentially wasn't needed.
Totally. And Lucy, we'll end with you for today. Anything you want to share with us?
Yeah, so for me, it would be a combination of what both Neil and Ishan said. I know my initial knee-jerk reaction when seeing the labs was to think about an empyema. So it really highlighted the importance of keeping an open mind and not closing in on that one diagnosis without considering the whole picture.
That's great. Good pearls from everybody. Thank you all for coming on the show. This is a real pleasure for us. Thank you all for tuning in and listening. Make sure you join us in 2 weeks for our next episode. This episode was written, produced, edited by myself and Christina Montemayor, and we'll see you next time.